Hello, I'm Dr. Robert Steiner, clinical professor and medical geneticist from the University of Wisconsin School of Medicine and Public Health in Madison, Wisconsin. Welcome to this program titled The Role of Timely Diagnosis in Optimal Management of Cerebrotendinous Xanthomatosis. Joining me today are Dr. Ritesh Ramdani, who is director of the Deep Brain Stimulation Program at Northwell Health in Great Neck, New York, and Dr. Ernst Schaefer, who is professor and senior scientist at Tufts University School of Medicine in Boston, Massachusetts, as well as Dr. Deborah Vanderveen, who is associate professor of ophthalmology at Harvard Medical School in Boston, Massachusetts. Welcome. Today we will be discussing the importance of early diagnosis and the consequences of delay in diagnosis and treatment of cerebrotendinous xanthomatosis. We'll call it CTX for short today. Let's begin with an introduction and some background on CTX. CTX is a rare autosomal recessive disorder of cholesterol and bile acid metabolism that can result in significant systemic and neurologic abnormalities. How frequent is it? Many of you may never have heard of this condition. Well, it turns out it's not ultra rare. The incidence among Americans is about 1 in 72,000 to 1 in 150,000 births. Several hundred cases have been reported in the world's literature, but the number of undiagnosed and possibly even misdiagnosed cases is unknown. Symptoms may begin in infancy with chronic diarrhea, or in some cases may first become apparent in adulthood. Learning disabilities and cognitive impairment often become evident in childhood, whereas premature bilateral cataracts frequently present in childhood or adolescence. Deb, would you mind telling us about the cataracts in CTX?
Yes, thank you. Bilateral cataracts are a clinical hallmark of CTX reported in 76 to 88% of affected individuals. Childhood onset bilateral cataracts are a common presentation in patients with CTX. However, it's highly unusual for children to come to us already diagnosed with CTX. Therefore, when we look at children with cataracts, there are a couple of things I'd like to point out. The first thing is that these cataracts are not congenital, they're acquired in the first or second decade of life. Secondly, there are some morphologic features that I feel are characteristic of these cataracts that ophthalmologists can look for. The first set of images comes from a multi-center study in which children with idiopathic cataract were sent for CTX testing. Out of 170 individuals, 3 were diagnosed with CTX. All of these were adolescents. The images in this slide can show you that there were some fleck opacities in the anterior cortex of the lens. There were also scattered opacities throughout the lens and some posterior subcapsular opacities. We can also see some scattered opacities, but the really interesting is the one on the bottom right, and this is with retroillumination. And you can see here, these deposits are scattered really throughout the lens, and this posterior subcapsular plaque is present. This patient was picked up because it was a familial case of CTX, and this child was only 8 to 9 years old at the time of diagnosis. And it's important that these are found usually prior to the development of other symptoms, so that cataracts are often found early.
Now, tendon xanthomas may develop in the second and third decades of life in these individuals, but are not present in all patients. Significant neurologic impairment can emerge really at any age, and you'll hear more about that from Dr. Ramdani. Neurological symptoms typically begin in the second and third decades of life with progression until death, often in the 5th or 6th decade of life, if the condition goes undiagnosed and untreated. Because the clinical phenotype is highly heterogeneous and the condition is rare, many cases go undiagnosed for many years after symptom development. Ernie, as a lipid disorders expert, would you tell us a bit more about xanthomas and CTX and whether any features differentiate them from those that we see in the more common conditions?
Yes. on the slide of the xanthomas and CTX, on the left, you see Achilles tendon xanthomas that are very striking. And we do see these in children with familial hypercholesterolemia. But if you see these xanthomas, especially the kind you see on the left, and the cholesterol levels are normal, then that is a tip-off to this disease, CTX. The patient on the right has very atypical tuberous xanthomas that are much less common, in this case on the hands. But the tendon xanthomas that you see on the left are more typical. This patient actually had surgery to remove these, and they always came back. So she's been followed for more than 35 years, and the xanthomas have been quite stable at this size.
Thank you. I want to talk now more about the metabolic defect and then the genetic defect causing CTX. CTX is due to defects in the CYP27A1 gene, the cytochrome P450 family 27 subfamily A member 1 gene, which codes for the enzyme sterol 27 hydroxylase. Deficiency or lack of the sterol 27 hydroxylase enzyme causes a lack of chenodeoxycholic acid, we'll abbreviate that CDCA, production, and high plasma cholestanol levels. I wanted to highlight the metabolic defects in CTX. CTX results in bile acid deficiency and accumulation of bile alcohols and cholestanol. So bile acids are made from cholesterol through a very complex series of enzymatic reactions. The final products of cholesterol to bile acid synthesis are the common bile acids, cholic acid and chenodeoxycholic acid. The enzyme 27-hydroxylase, the sterol hydroxylase enzyme encoded by the CYP27A1 gene, is important in the metabolic pathway of production of those bile acids. So when that enzyme is deficient, those bile acids are not made in normal amounts, and in fact, CDCA may not be made at all. The other important byproduct of the enzyme deficiency is accumulation of potentially toxic precursors in that metabolic pathway. And most specifically, cholesterol is converted to cholestanol when that enzyme is blocked, and there's also accumulation of bile alcohols. This accumulation of cholestanol leads to deposition of the compound in tendon, ocular lens, and brain, and that's responsible probably for a lot of the complications that are seen. We've known about the gene defect in CTX for quite a while. In fact, in 1991, the CTX gene was first identified. In 2001, there were a series of patients reported with 23 different CYP27A1 mutations identified in 13 individual patients. I mentioned earlier, this is an autosomal recessive condition, and there are founder mutations in certain populations such that the condition is quite frequent in these populations. And the two best examples are the Druze in the Middle East and Jews of Moroccan origin. Diagnostic confirmation by CYP27A1 gene sequencing, or these days more commonly multi-gene panel or genomic sequencing, either whole exome or whole genome sequencing, is used more and more as the type of testing is more widely available. Ernie, would you now take us through a case that I think demonstrates many of the features we've been discussing?
Yes, this was a female patient who was noted to have developmental delay as a child, stopped talking at age 4, and then she had 2 years of speech therapy before she started talking again. That actually is somewhat unusual. At age 5, she developed significant chronic diarrhea and failed to gain weight normally. She then developed cataracts at age 8, which required multiple bilateral cataract surgeries. And in her teenage years, she began to experience progressive mental decline and dysarthria. And her IQ was documented to be low at 56. At age 31, she was finally diagnosed with CTX based on having a serum cholesterol level, which was 30. Normal in the lab that she had it measured was less than 4. In many labs, it's less than 5 milligrams per liter. And she was begun on therapy with chenodeoxycholic acid, 250 milligrams PO 3 times a day. And she was treated with some other therapies as well. Her brother also was noted to have CTX at the same time, and his neurological disease was quite a bit worse at the time. And he was 2 years older. At age 48, she was doing well and was able to work part-time in a grocery store. She was able to walk independently, and her diarrhea had improved significantly. Her liver enzymes and alkaline phosphatase and bilirubin were all normal. So the goals of therapy in a late diagnosed patient such as this are to slow down or even halt the progression of disease and try to preserve cognitive function and ameliorate or stabilize neurological function. This case is actually typical. Most cases, unfortunately, are not diagnosed until they develop significant neurological symptoms.
Ritesh, can you please take us through the second patient case?
Yes. So this is a female patient who had delayed milestones, specifically walking and talking, and as well as learning disabilities requiring special education in childhood. At age 36, she had a significant decline in her motor function, emergence of a resting hand tremor, gait ataxia, and periods of dysphagia. At age 38, she was diagnosed with CTX based on an elevated plasma cholesterol of 17.5, with normal being less than 5. This was confirmed by genetic testing of the CYP27A1 gene mutation as well. And at the time of her diagnosis, she also had bilateral cataracts and tendinous xanthomas. She was placed on CDCA of 250 milligrams PO TID as well, and in the subsequent month had a notable improvement in her cognition. She was more talkative, she participated in daily activities, and her mental clarity was also better. In terms of her physical symptoms, her hand tremor resolved, and she had improvement in her ambulatory status with but required persistent assistance with getting around. The goals of treatment for this case, similar to the first case, is not to only lower the cholesterol accumulation, but to also try to reverse and to stabilize her mental status and other neurological symptoms.
Ernie, what are the hallmark clinical signs and symptoms of CTX?
So often it's the diarrhea that comes first, but not always, and premature cataracts, but they don't always occur, but they do occur quite frequently. Then the next thing that often occurs is actually the tendon xanthomas, usually in their 20s. And then finally, more progressive neurological signs and symptoms. And unfortunately, the diagnosis is often missed until they get significant neurological problems.
Ritesh, what about the neurologic signs and symptoms more specifically?
CTX affects both the peripheral and the central nervous system, including the cerebellum, the corticospinal tract, the spinal cord, and the basal ganglia. We could see neurological symptoms develop throughout the life of a CTX patient, but it becomes particularly evident usually in the second and third decade of life. Cerebellar ataxia and dysarthria are some of the more common presenting neurological symptoms that also coexist with pyramidal dysfunction, which manifests oftentimes as a spastic paraparesis or a spastic ataxia with hyperreflexive signs. Cognitive dysfunction is also very common. As mentioned earlier, we could see learning disabilities present in childhood, and as time goes on, these patients can go on to develop dementia later in life. Sensory changes such as peripheral neuropathy, as well as basal ganglia disorders such as Parkinson's, dystonia, and tremor, though rare, can still occur later in adulthood. Seizures also are fairly rare in CTX, but we could see them as well manifest throughout life. Some of the brain abnormalities we find in CTX patients who have neurological symptoms. We characteristically see bilateral hyperintensities in the dentate nucleus with surrounding gliosis of the cerebellar white matter. These white matter changes can also be seen and have been reported to occur in the corticospinal tracts as well as the basal ganglia. In addition, global reduction in cerebral as well as cerebellar gray matter is not uncommon.
Ernie, let's focus now on diagnosis and treatment.
Yeah, thank you. The clinical findings in neuroimaging and biochemical testing, what's commonly done is when you see a patient, especially with the xanthomas or the early cataracts or the neurological disease, and people think of the diagnosis, they need plasma or serum cholesterol levels measured. They're, as indicated, usually more than 3 times the upper limits of normal, which is about 5 milligrams per liter. And the cholesterol levels, on the other hand, tend to be normal or in the normal range, but not very high. And then, of course, now we have genetic testing since the gene for this disease was identified. And so if somebody has xanthomas and a normal cholesterol, think of this disease. If somebody has premature cataracts, think of this disease. And also when that's coupled with developmental delay, learning problems, then we really need to think of the diagnosis here and get the lab testing and the genetic testing done. The treatment, so chenodeoxycholic acid, or CDCA, was actually approved by the FDA in 1980 for the dissolution of gallstones. Of course, nowadays people don't wait for that. They have the gallbladder removed by laparoscopy. But it was also approved in the European Union to treat adults and children with CTX over 1 month of age. In the United States, it's widely used off-label for CTX because it is really considered the standard of care in the United States and worldwide. So the CDCA reduces abnormal bile acid synthesis because you're giving the body the bile acid that's not being made. And that does decrease the levels of cholesterol from about 30 or so, ideally to less than 5. And we think that is really important for stabilizing the disease. So the treatment is most effective when started early. This therapy is usually well tolerated, occasional GI side effects and elevated liver enzymes. But if you follow the patients longer, usually the liver enzymes will normalize. Obviously, there's a contraindication if there's liver dysfunction, significant liver disease, or bile ductal abnormalities. So a very important study that was done by Bergener and Zalen, 17 CTX patients were studied. Their mean age was 33. 100% of them had evidence of neurological disease. 88% had xanthomas. About 83% had abnormal CT scans. 76 had dementia. 71% had cataracts. And as I mentioned, various neurological changes. After 1 year, more than 1 year of CDCA treatment, the dementia cleared, the pyramidal and cerebellar signs and peripheral neuropathy either improved or disappeared. And what was surprising, EEGs actually improved or became normal in 86%. And the plasma cholesterol levels were decreased more than 3-fold, and the CSF cholesterol levels were also markedly decreased. In another study, which was done in Italy, again, the mean age of diagnosis in these 19 patients was again about 33, again, mainly because of neurological disease. 84% of them had cataracts. 79% had xanthomas, 74% had cognitive dysfunction, and about 68% had neurological disease. So they were treated again with CDCA, 250 milligrams TID, and the levels of cholesterol decreased from 34 to 3.8 milligrams per liter, while cholesterol levels just changed slightly, about 11%, from 187 to 165. Treatment in this series resulted in significant improvement or stabilization of symptoms and signs of the disease. So in a subgroup where the disease progressed despite therapy, this was mainly the patients with advanced neurological disease. So it's really important to think of the diagnosis and diagnose this disease before they develop significant neurological disease.
Thank you. Deb, can you tell us about another clinical study that illustrates the need for early diagnosis and treatment?
Yes, and this actually speaks to the point that we were just discussing. This study was a collaborative study looking at the diagnosis, treatment, and clinical outcomes of 43 cases in the United States. Again, the mean age at diagnosis was 32 years. The range in this was 8 to 55 years. And as you can see from the percentages, 70 to 80% had one of the major symptoms, with 81% with neurologic disease, tendon xanthomas in 77%, cognitive impairment 74%, cataracts in 70%, and diarrhea in more than 50%. These patients, most of them were treated with a similar dose of CDCA. And prior to treatment, the mean cholesterol was 32 milligrams per liter, and this decreased post-therapy to about 6 milligrams per liter. And 63% achieved normal levels that were less than 5 milligrams per liter. Fortunately, most of these patients on treatment, 57% improved and 23% stabilized, but unfortunately, again, 20% deteriorated, and those were the patients who had advanced disease before they started receiving treatment.
This is becoming, I think, a theme that the patients who seem to deteriorate are the ones with advanced disease. So I think this drives home the point that it's really important to try to diagnose and begin treatment early. Let's talk a bit about potential alternative treatments. The first one I'd like to mention is cholic acid. You remember from the metabolic pathway that cholic acid production is reduced in CTX, probably not as severely as CDCA, but nevertheless it is reduced. Cholic acid can help reduce cholesterol levels in patients with CTX. The dosage is similar to CDCA. It's 10 milligrams per kilogram body weight per day. Now, cholic acid has shown some efficacy in this condition, but has not been very widely tested, and it may not inhibit cholesterol formation to the same extent as CDCA. It is sometimes used as an alternative for patients who can't tolerate the side effects of CDCA, and it lacks the hepatotoxicity warning that's present in the drug label for CDCA. Adverse reactions are rare, but can include diarrhea, esophagitis, malaise, jaundice, skin lesions, nausea, abdominal pain, intestinal polyps, urinary tract infection, and peripheral neuropathy. And there is a warning of exacerbation of liver impairment. What about other potential treatments? Ernie mentioned surgical excision of tendon xanthomas. And in the patient he mentioned, the xanthomas always grew back after surgery. That is a common observation. So generally, it's not recommended to excise these tendon xanthomas surgically. Other alternative treatments that have been tried in cohorts of patients include apheresis, as well as adding statins, HMG coenzyme A reductase inhibitors, to the CDCA. The bottom line is that in most patients, CDCA alone should be efficacious, but if not, or if side effects occur, one should consider these other alternative therapies. Now, you've heard a lot about the goals of treatment already. The goals include replacing the deficient CDCA, lowering cholestanol levels, and preventing, ameliorating, or stabilizing systemic and neurologic complications depending on the patient's stage of disease. I wanted to spend a little bit of time talking about the potential for newborn screening for this condition. Imagine if you could diagnose this condition shortly after birth and start treatment right away, you might be able to prevent some, if not all, of the complications. In CTX, we know that early diagnosis and treatment is critical for optimal outcomes. CTX fulfills many of the criteria required for newborn screening, but lacks a suitable, sensitive, and selective test that's been validated in a large population. Now, recently, an assay utilizing tandem mass spectrometry allows quantification of a ketosterol bile acid precursor, we call 7-alpha-12-alpha-C4, in dried blood spots, the same dried blood spots that are used in newborn screening in general, and that can discriminate between CTX and unaffected newborns. A newer assay based on the different ratios between accumulating cholesterol tetroglucuronides, or tetrol, and specific bile acids or bile acid intermediates, showed that a tetrol to bile acid ratio had excellent separation between CTX and controls, such that this biomarker really has the potential for use in newborn screening. With regard to concluding remarks, although CTX is rare, it is underdiagnosed, as the presenting signs and symptoms are nonspecific and there's significant overlap with other more common conditions. There's also marked variability in the signs and symptoms of disease, as well as the severity and the age of onset between patients. We've stressed a number of times that early diagnosis and treatment in CTX are imperative to prevent potentially irreversible neurologic damage. And finally, patients presenting with symptoms overlapping the clinical phenotype of CTX should have a thorough workup. The diagnosis is made by the finding of a plasma or serum cholestanol level elevated typically approximately 3 to 10 times the normal level in the absence of significant cytosterol elevation or extremely high LDL cholesterol, and should be confirmed by genetic testing. The therapy of choice is oral CDCA, 250 milligrams orally 3 times daily in adults, or 10 milligrams per kilogram body weight per day in children. These conclusions are supported by worldwide longitudinal cohort studies beginning all the way back to the 1970s and by multiple individual case reports and reviews. I want to thank Ritesh, Ernie, and Deb for participating in this activity. And thank you for participating in this activity. Please do continue on to answer the questions that follow and complete the evaluation.